So our next speaker is Dr. Ilene Weitz, who's an associate professor of clinical medicine at the Keck School of Medicine at the University of Southern California. She trained at the Medical College of Pennsylvania in Philadelphia and received her medical degree there, followed by further training and internship and residency at Cedars-Sinai Medical Center, and then did a fellowship in Heme-Onc at Scripps Clinic and Research Foundation in La Jolla in California. She is a renowned expert, as you've already heard by her questions, in many aspects of classical hematology, but has a particularly special interest in cold agglutinin disease, a disorder initiated by a pathway that I'm particularly fond of discussing. So, Ilene, we're pleased you're here.
Yeah, so I trained with the dinosaurs. So I trained with some giants in hematology, with Bill Crosby and Ernie Beutler, who were leaders in the field. So, but I have a particular interest that I share with Ed in complement-mediated diseases, and many of you may have heard me speak about PNH and AHUS in the past. But I'm going to concentrate on cold agglutinin disease, which is actually a fascinating disease and really links the innate immune system with the acquired immune system. So your basic immunity with antibody-mediated immunity. And it's a perfect example of that. So these are my conflicts, none of which are really relevant today. And so the objective of this talk is to get you to understand what primary cold agglutinin disease is versus cold agglutinin syndrome, the pathophysiology, which is really pretty fascinating, and the role of complement in CAD and how to manage it. And we have new ways of managing cold agglutinin disease. So you've all seen this smear when you look at a smear. Okay. And in fact, I was doing rounds one day in November, and we looked at the blood smear, and I said, this patient has cold agglutinins. And it was, quote, an autoimmune hemolytic anemia patient. And indeed, she had cold agglutinin disease. So it's pretty obvious it's not just a bad preparation. So these are CAD is a very sort of schizophrenic disease. There are parts of the disease that are driven by the antibody, and there are with agglutination, and that accounts for the acrocyanosis, the Raynaud's, the livedo reticularis, and the gangrene that you can see, and as you can see in the pictures. And then there is the hemolytic component that's really driven by complement. And I think that this sort of separation of the two gets a lot of people confused. So we know that if you look at the types of cold agglutinin disease, that you can see hemolytic anemia alone or with very little symptomatology, or you can see hemolytic anemia with the circulatory findings, or sometimes you can just see the circulatory findings itself. And you can see the percentages. Most patients will present with some component of hemolysis. Now, is there an effect of the seasons? So I live in Southern California. We don't usually get that cold, right? And we do see, just as an observation, we see more cold agglutinin disease in the winter, because we can drop down into the 30s and 40s versus the summertime when we never see cold agglutinin disease. Well, Berenstain and Alexander Roth looked at this, and they didn't see all that significant a difference, but you can you see the pointer? Okay, you can see that a little blip in bilirubin and a little drop in the hemoglobin in the wintertime. So for us, it may be more significant. Now, the other interesting thing about cold agglutinin disease that we don't really think about is that it is associated with an increased risk of thrombosis. And that's not really from hemolysis. It's just like in other hemolytic processes. It's due to the inflammatory effects of the disease, which stimulate thrombosis. And this is from Catherine Broom's assessment. She looked at the Optum Healthcare database, and they looked at cold agglutinin patients matched for age without CAD, and you could see, again, a higher incidence of thrombosis, and more on the venous side, but some arterial ones as well. Now, cold agglutinin disease occurs in older people, so there is an increased risk of thrombosis just because they're older. But this is above and beyond, as you can see when you look at the comparative group. And it's probably due to the activation of complement and the interaction of complement with the coagulation cascade. I won't go into all the details because it'll take me till next year, but you see increased platelet aggregation, you see tissue factor expression, and you can see increase in tissue factor bearing microparticles. We know, for example, in the PNH data that you get red cell microvesicles, but even with treatment, those continue to circulate, and they don't express tissue factor. So they don't play into the thrombotic complications of the disease. If you look at morbidity and mortality, if you have a thrombotic event in CAD, you're going to die sooner. So what are the causes of cold agglutinin disease? It is an autoimmune disorder. It's a hemolytic process. It can be transient, and we see that with the infectious forms of cold agglutinin syndrome, mycoplasma, and mononucleosis. For those of you taking boards, just remember that mononucleosis is unique in that the antibody is directed to the little I antigen, as compared to mycoplasma, which is a big I antigen. There are secondary cold agglutinin syndromes due to lymphomas of varying types, but cold agglutinin disease is defined as having, as being less than 5% lymphocytes in the bone marrow, but although they are clonal, but they don't meet the criteria for lymphoma. Oops, sorry. So one of the problems with cold agglutinin disease is making the diagnosis. So you have to be careful when you collect the samples. Remember that at room temperature, you'll get agglutination. And so all the tubes have to be warmed. So I had a patient who came in, and I got a call from the lab saying that her cells were agglutinated. And I said, but guys, she's got a known cold agglutinin. So I put a big sign up in the lab, this patient's coming in, warm the tubes, or bring the little heat block down, which they never do. So I said, okay, stick it in your bra, stick it in your pants, something that's warm, because if you just leave it out on the table, everything's going to agglutinate. So it becomes a real issue for these patients. And that's true for whether you're doing flow or whether, especially if you're going to do a thermal amplitude. All right, so what's the pathophysiology? So you have this low-grade lymphoproliferation. It's usually kappa marking cells and plasmacytoid lymphocytes, and they produce an IgM, and this IgM binds red cells by either the big I, mostly big I, at 4 degrees. The broader the thermal amplitude, the more likely you are to see hemolysis. And so at 22 degrees, you get complement activation. And once you get complement activation, then at 37 degrees, you'll get active complement, and you will lose the antibody, so you won't pick up the IgM, but you will have C3b tagging these red cells. And once there's C3b on the red cells, C3b is the quarterback of complement. It controls a lot of function, but mostly it's the opsonization point, the amplification point to complement. So these cells are going to get picked up by the macrophages, mostly in the liver, not the spleen, but mostly in the liver, and they'll be picked out and destroyed. You can go on to get intravascular hemolysis through the activation of the terminal complement complex as well, although that is less common. Most hemolysis in CAD, in cold agglutinin disease, is extravascular. And so here you've all seen, remember this from medical school, that at 4 degrees you stick the tube in an EDTA tube in ice, and you lift it out, and everything's agglutinated. So, and then you activate the complement, and then you get phagocytosis of these C3b-coated cells. And you can mark that on flow cytometry. Occasionally, you can get intravascular lysis. So how do we treat this? It is really interesting. In Sir John Dacey's treatise from 1961, he talks about cold agglutinin disease and autoimmune hemolytic anemia. And the one patient he had who died of a thrombotic event, and that was a CAD patient. I thought that was really interesting. So it's been in the literature for a long time. Well, we do all the therapies you would think about: cold, wear long sleeves, avoid the cold, gloves. I had a patient who actually was on an agent I'll talk about in a little while, who ran outside to get the newspaper, and it was last March, which is normally not cold for us, but we had a really cold storm come in. By the time she got back in the house, she didn't wear shoes, she ran out to get the paper. By the time she got back into the house, she had purple feet. Purple feet. So, it's still a problem. You want gloves, hats, socks, etc. Hemotimics. If you're going to give transfusion, we usually use a blood warmer because the blood, one, may be stored cold and it's not warmed up that much so you don't get degradation. Plasmapheresis can be done. You can use ESAs, and then there are cytotoxic agents that have been used, but not very successfully. There is no role for corticosteroids, and I can't tell you how many patients who have come in who have been on long-term steroids. And there's no role for splenectomy or IVIG, and I've seen all of these used in the community. Currently, you want to think about treating the underlying clonal disease, but these are not necessarily the most responsive lymphoid proliferations. You can use rituximab, and there's a partial response rate of about half of the patients, CR is rare. You can add fludarabine, cladribine, but it's pretty toxic. And probably the least toxic, especially for this older population, rituximab and bendamustine has been used. There were clinical trials using eculizumab to block terminal complement, and there are some ongoing studies using ibrutinib and some of the proteasomes as well. But I'm going to talk a little bit more about sutimlimab, which has been approved and is very effective in blocking hemolysis and blocking complement. Chemotherapy for CAD, again, bendamustine, rituximab, and you could see response rates are pretty good. About 40% get a CR, 30% get a PR. And it's durable, so it lasts for a while. So what's the role of complement in cold agglutinin disease? Well, it's really part of our innate immune system, and it sets up a pro-inflammatory, pro-thrombotic milieu. We know that it increases cytokine production, including TNF, IL-6, IL-8, IL-17, and it also works through the produces these anaphylatoxins, C3A, that recruits white cells into the area, and C5A, which is a very potent inflammatory and prothrombotic protein. It increases markers of vascular inflammation like soluble TNF and VCAM. It releases pentraxins like C-reactive protein. And it's very important in complement-mediated inflammation and cytokine activity, and that contributes to the symptomatology these patients have, one of which is severe fatigue. And we know that it's not just the anemia that's causing the fatigue. And you see that in AHUS, you see that in PNH, other complement-driven disorders. And finally, it causes hemolysis. So it's really the bridge between the innate and adaptive immune systems, and as you can see, so here is your antibody, here's the complement complex, it binds to the C1s, to the C1q RNS, and then generates C3 convertase. And then C3 convertase then leads to the generation of C3b and C3a, C3b going on to be the amplification point, and also to the generation of C5 convertase, leading to C5b, which then goes to fixes terminal complement to accomplish the next function of complement, which is to punch a hole in a membrane. Very primitive, not selective, and C5a, that's a very potent inflammatory protein. So is there a way that we can block complement to reduce the morbidity of this disease? And the answer is yes. And eculizumab's been available for over 15 years now, and has been looked at in cold agglutinin disease. Pegcetacoplan, which is a C3 inhibitor that's been approved for the use in PNH, and then sutimlimab, which blocks the C1s and then blocks the generation of the ultimately C3 convertase. So this was done in this was studied in several different populations. The first trial was the Cardinal trial, where they looked at patients who had hemoglobins less than 10, and they had active hemolysis, and they had a requirement for at least one blood transfusion in the last 6 months before enrollment. They were not treated with rituximab for at least 3 months, and most of them had failed previous therapy or any combination therapy. And cold agglutinin syndrome was excluded. And you can see the response rate. So the blue line is the hemoglobin, and within the first week, it starts going up, and by 4 weeks, it is up, and it stays up. If you look at the bilirubin, it's inverse, and it goes down, and it starts pretty fast, and by the third or fourth week, it's down. And you could see that the hemoglobins went up in transfusion-dependent patients. 83% went up more than 1.2 grams. 62% went up more than 2 grams, and a third of the patients had a 3-gram increase in their hemoglobins. So highly successful in stopping complement-mediated hemolysis. So cadenza was a phase 3 placebo-controlled trial, hemoglobin less than 10.5, multiple symptoms for CAD, but less than 1 transfusion in a year. So this was a, quote, milder population. And again, you could see the same thing. You can see that here's the sutimlimab arm, and it goes up pretty nicely. And here's week 4, the hemoglobins are up to 12. Is that showing up? No? What happened to the mouse? Here, let me do this. Here. There we go. So here you could see the hemoglobins, and they go up really nicely, and once they're up, they stay up. And if you compare that to the placebo group where there was no improvement, and they stayed around 9. If you look at all the other parameters, if you look at the bilirubin, it goes down. If you look at the haptoglobin, it goes up. And you look at the LDH goes down. And you look at the reticulocytosis, that also goes down, indicating that there is resolution of the hemolysis. The other interesting thing is if you look at IL-6 as a marker of inflammation, an inflammatory cytokine, you could see a decrease in the IL-6 by week 1. That's in the red, okay? Goes down starting at week 1, and once it's down, it stays down. And if you look at the facet fatigue response, okay, which is in green, you could see it's inverse with the facet fatigue. So this is even before the hemoglobin's getting better, or has gotten better. And so, again, suggesting that the fatigue in these complement-driven diseases is really related to cytokine activation. And you can shut that off with a complement inhibitor. And here you could see the Weitz lab suppression of the complement activity. And it goes down within the first week. So. Well, what does it do in terms of the thrombotic complications? Well, in fact, you do see that D-dimers and TATs go down with treatment, just like we've seen with other disorders. So, again, suggesting that manipulating the complement system really does suppress the hemostatic system. So, how do we treat these patients in 2024? Well, you can watch and wait if they're really asymptomatic, but you need to make certain they're really asymptomatic. Or if they have anemia, if they have cold agglutinin symptomatology, if they have gangrene, Raynaud's, et cetera, you might want to treat. And you can treat with BR if the patient's willing. And on the other hand, you can watch and wait, and if they have really profound anemia, you can treat with a complement inhibitor with sutimlimab, and then potentially transition to B-cell therapy. And, rituximab takes about 6 weeks to kick in. So if you have a really anemic patient, by treating with sutimlimab first, you might be able to get them through that anemia period. And again, the role for ibrutinib or bortezomib, these are all in clinical trials right now. There is a new agent, riliprubart, that is a long-acting C1s inhibitor. It actually binds to the active C1s. So C1s exists in its inactive form, and then it's converted to its active form when it binds to the C1R component. And this was presented at ASH. Shirley Desaz did the presentation, and you can see that very nice responses in terms of hemoglobin, but you can go out 15 weeks. So one of the problems with sutimlimab is that it's given every 2 weeks, and that's a real pain for the patient. They have to come in and get it. So, but this will be available to be given. It's going into phase 3 trial, and it will be give the patients very long-acting suppression of C1s. And I think that's it, and I'll stop. This was taken on, my daughter and I went to Southeast Asia, and we went on a night food tour in Ho Chi Minh City. by motorbike. Ah, what fun we had.
It looks like it.
It was great. Yeah, questions?
Ilene, thank you so much for a great presentation. I'm here, we've met before.
Yes.
So I just want to say, it all looks very exciting for cold agglutinin disease. And before any of these folks get too excited, let's bring you right back down for Canadian context. Sutimlimab, I had the only patient in Canada in that trial, did extremely well. The company decided against filing with Health Canada. If you don't file with Health Canada, you're under no obligation to provide compassionate access. Done. We moved on. So became pegcetacoplan. We opened a trial, sponsor terminated the trial, no longer available. Really bruised stop, I can't even say that word. We were approached by the sponsor, they decided against Canadian participation.
Yeah,
so somebody asked a really poignant question about regulatory and other so forth market in Canada. It's tough. If you have a rare disease in Canada, it's a very tough going. So for now, yes, we can go on with chemotherapy, but a lot of these patients are elderly and already beaten up by a lot of chemotherapy. And unfortunately, complement blockade is where we want to be, but it's just not a reality, which is very, very sad.
It is, because it's very effective therapy. So at least in the short term, it's like all these drugs, they're very expensive. We have to jump through a gazillion hoops, to get these drugs. And the perfect example is we had a patient with autoimmune hemolytic anemia, known, and then came in with an exacerbation, and it turned out she's the one whose slide that was. She has a cold agglutinin. And she was at the county hospital. So I said, this is a drug of choice. I got screamed at, and I ordered this drug, and her insurance says that she has to get it through her other provider. So I talked to the other provider. I said, this is what she needs. She'll do fine with it. We have 2 other patients like this. And so then I was back on service in February. And she came back in. She has not gotten the drug yet. Because, they had to go through authorization, and they had to do this, and then her primary hematologist wasn't so certain. He was afraid to give the drug, and it was like, this could all been managed, and the county wouldn't do it because it was money out of their pocket. Of course, it's my tax dollars.
Yeah, hi, it's Ben from General Apologies. I find it very interesting that not everybody responds to BR, and then there's as you said, there's some trials going on for bortezomib. So what is known about the cell of origin? Is it antibodies produced by CD20 positive cells, or is it more downstream plasma cells where bortezomib might be more?
Yeah, well, they're plasmacytoid lymphocytes, so they're mostly kappa-bearing. They're much more mature than what we would see with a lymphoma. So they tend to be more mature cells. So whether or not, there is some data that ibrutinib-like medications are effective in autoimmune hemolytic anemia. We have that trial ongoing right now, and it looks like it is effective. So I have no doubt that it will probably be effective in cold agglutinin disease.
Thank you. I've seen some people comment that the trouble with sutimlimab is it doesn't actually target the B-cell clone, but your point is well taken that not everyone can actually tolerate chemotherapy targeting that. Do you suggest keeping people on sutimlimab indefinitely? Do you tend to just use it as a bridge to getting them to B-cell therapy, or where do you see it fitting in?
Well, I think, if you talk with people like Sig Berenstain and Catherine Broom and some of the other major players in cold agglutinin disease, that nobody wants to keep the patient on forever because it's expensive and you got to have somebody to pay for it. But that little algorithm that I showed you suggests that you can keep the patient on for a while and then start to treat them with a B cell inhibitor, with an antibody reducer. So I think that's the way to go. That's what we did with my patient who developed the blue feet. Yeah, she'd been on sutimlimab for about 6 weeks. And, you know, we watched and waited with her for about 6 months, and then she came in with a hemoglobin of 6. We said, okay, we need to do something. So she didn't want chemotherapy. So we treated her hemoglobin shot way up, and then she came in with these blue feet. So we decided, well, at some point we're going to need to intervene with something to reduce the antibody.
So I may have missed it. So what are the antigens, the autoantigens for this agglutinase disease?
They're usually big I is the antibody on the red cell.
Which one?
Big I, yeah.
Isaac Nazi from McMaster. That's a great talk. Possibly a similar question and maybe naive. Are the IgM antibodies low specificity, low affinity? What's the nature of them?
Yeah, that's interesting. So most of them are not, they're not high affinity antibodies. So, you know, as the cell warms up, they're held together by, like, the red cells are held together by sort of these van der Waals forces, and they're not covalently bonded to the red cell. So the antibody will float off. But what happens is that it's fixed the complement already. So the complement, once it's fixed on the cell, it is there. So
is there any work being done or looked at towards stopping the IgM from sticking to the red blood cells and not allowing that?
No, not that I'm aware of,
Yeah.
but I'm not aware of that.
Okay, thank you.
So.
Yeah, so kind of a follow-up to these ones, but looking at the target, right, this big I mean, it's interesting because normally, biochemically speaking, at lower temperature, binding is lower, right? So is there a structural change in the antigen?
No.
Or the surface of the red blood
I
cell?
don't think so. I don't think so. And there's a difference between big I and little I in terms of the carbohydrates, I think. But no, there's no difference. I think the real issue is that the way the antibody binds, it is sort of a loose association. But the problem is that once you bind the complement, then you get hemolysis.
Thanks.